Clinical trials have long been the primary way we test the effectiveness of healthcare interventions for older adults. Broadly, trials fall into two categories: explanatory and pragmatic. Explanatory trials test whether an intervention works under optimal conditions. Pragmatic trials evaluate how well interventions work in real-life practice. Pragmatic trials have gained momentum in recent years because many findings from explanatory trials often fail to produce results that are seen in routine practice. Why do some clinical trial findings not translate easily into everyday practice? This challenge can be especially important when studying interventions for older adults living with multiple health conditions. Many trials are designed to test interventions under ideal conditions, not the realities of everyday care. That's where pragmatic trials come in. They aim to test interventions in real-world settings. In our first video, which we have linked in the description, we introduced the concept of pragmatism and the PRECIS-2 tool, a framework that helps researchers design trials intentionally along the explanatory to pragmatic spectrum. In this video, we're taking it a step further. We'll explore how the PRECIS-2 tool can help researchers think through key design decisions and position a trial along the explanatory pragmatic spectrum, using a real case example of a diabetes intervention for older adults. The limited generalizability arises from features typical of explanatory trials, such as excluding those with multiple chronic conditions, which are common in older adults, emphasizing standard protocols that fail to recognize the heterogeneous nature of aging, prioritizing clinical endpoints instead of outcomes that matter most to older adults, and implementing interventions under highly controlled conditions that are not feasible or sustainable in everyday care settings. Interestingly, the same characteristics that strengthen scientific validity of explanatory trials, like the exclusion criteria and standardized protocols I just mentioned, can reduce the ability to generalize to broader populations and real-world settings. This video explores how these and other design features can be tailored to move the design needle in the direction of pragmatism so that generalizability is enhanced without losing scientific validity. We begin by providing some background on the intervention and the prior research done that led up to conducting a large clinical trial where the PRECIS-2 tool was used to select the trial design features. Let's dive into our case example, the Community Partnership Program, or CPP. The CPP is a community-based diabetes self-management program designed for older adults living in the community with multiple chronic conditions. What makes it stand out is how it was developed. Researchers at McMaster University's Aging, Community, and Health Research Unit, also called ACHRU, worked alongside with healthcare providers and older adults to co-design the intervention. This collaboration helped ensure the program was not only evidence-informed, but also practical and relevant to the people it was meant to support. Earlier studies showed strong promise. The CPP had been tested in a pilot study and then in a clinical trial, where it was found to be feasible to deliver and effective in improving quality of life, diabetes self-care behaviors, and depressive symptoms. While the findings were encouraging, the participants in these earlier studies were not fully representative of the broader population of older adults living with diabetes. Most were not medically complex, and they lacked diversity in ethnicity, culture, and geography. This gap set the stage for a larger, more pragmatic trial, one designed to test the intervention in more diverse, older adult patients and settings. To do that, the ACHRU team used the PRECIS-2 tool to guide the design and make sure the trial leaned toward pragmatism while maintaining strong scientific integrity. Now let's walk through how each of the 9 PRECIS-2 domains shaped the design of this trial and how the trial was rated. Domain 1 focuses on participant eligibility criteria. In a highly pragmatic trial, eligibility criteria aim to include participants who reflect those seen in everyday care settings. In the case of the CPP trial, for example, this would include older adults with diabetes from outpatient clinics and primary care practices. This meant not excluding individuals based on anticipated non-adherence, unavailability, or non-responsiveness to the intervention. It also meant ensuring inclusion of individuals with characteristics common in this population, including multiple chronic conditions, particularly cardiovascular disease, chronic kidney disease, and retinopathy. Functional limitations, including frailty and cognitive impairment, treatment management challenges, such as managing dietary and physical activity limitations, polypharmacy, and attending multiple medical appointments. And sociodemographic factors, with diabetes being more common in lower income and certain ethnic groups, such as Indigenous, African, South Asian. Overall, we assigned a score of 4 out of 5 for Domain 1 because eligibility criteria were broad and reflective of real-world patients with only minor constraints. Domain 2 focuses on how participants are recruited. A highly pragmatic recruitment approach would involve identifying participants that naturally present to usual care appointments at a range of primary care clinics to increase the applicant pool. No special recruitment efforts such as media advertising or incentives would be used. For the CPP trial, we recruited directly from usual care settings. We selected 3 Canadian provinces with 2 community-based diabetes clinics or primary care settings in each province. Recruiters used clinic registries and electronic medical records at participating sites to identify eligible patients, and clinicians approved who could be approached. While recruitment was carried out by existing staff, compensation was required for the additional time involved, which slightly reduced pragmatism. Overall, recruitment aligned well with real-world practice, with only limited added resources required, resulting in a score of 4 out of 5 for Domain 2. Domain 3 focuses on the setting where the intervention is delivered. A highly pragmatic approach includes sites that closely resemble where the intervention is intended to be implemented and scaled up. Pragmatism is reduced when trials are limited to a single site or a narrow subset of settings. The CPP trial involves 6 primary care sites delivering diabetes education programs, such as diabetes education centers. These sites collaborated with a community-based partner, such as the YMCA. The community-based organizations already had established infrastructure and experience providing diabetes-related services. By selecting real-world, community-based settings suited for future scale-up, the trial reflected a highly pragmatic design. We assigned a score of 5 out of 5 for Domain 3 because the intervention was delivered in real-world community and primary care settings intended for CPP scale-up. Domain 4 focuses on the expertise and resources needed to deliver the intervention. In a highly pragmatic trial, interventions are integrated into the usual organization of care, using existing staff and resources wherever possible. The intervention was delivered in intended practice settings by providers who normally deliver care to this population. Some elements required additional training, such as motivational interviewing and managing multiple chronic conditions. However, this was not viewed as reducing pragmatism, since training is typically required when introducing a new model of care. However, some CPP components, such as home visits and group wellness sessions, went beyond routine care or were delivered differently at some primary care sites. Pragmatism was reduced at sites where additional resources or infrastructure were needed to deliver these CPP components. Overall, we assigned a score of 4 out of 5 for Domain 4 because the intervention was largely integrated into usual care, with only some sites requiring additional resources to deliver the CPP. Domain 5 looks at how much flexibility providers have in delivering the intervention. Highly pragmatic trials allow providers working in collaboration with patients to determine how the intervention is implemented, similar to what occurs in usual practice. Pragmatism is reduced by highly prescriptive protocols, close monitoring of provider compliance, specific direction for managing complications or side effects, and specific direction on co-interventions. In the CPP trial, providers were trained on key elements, such as motivational interviewing and goal setting, but they were not given rigid protocols or required to deliver a specific dose of intervention components. Providers were not closely monitored for compliance with the intervention protocol, and delivery was tailored based on patient needs and clinical judgment. Flexibility also extended to who delivered the intervention, with different health professionals involved depending on usual care at each site. For example, while the intervention was intended to be delivered at the community partner site by a certified diabetes educator, other healthcare professionals at the site that were part of usual care for diabetes patients were permitted to fulfill this role. Examples include pharmacists, certified nutritionists, and physiotherapists. Overall, intervention delivery was designed to be flexible and pragmatic, leaving specifics of how to implement intervention elements and who delivered them up to trained site providers. Overall, we assigned a score of 4 out of 5 for Domain 5 because providers were given flexibility in delivery with minimal guidance on the delivery of intervention components. Importantly, flexibility here refers to how providers delivered the intervention, not how participants chose to engage, which is addressed in the next domain. Domain 6 focuses on adherence to the intervention. In highly pragmatic trials, participants are included regardless of prior adherence, and flexibility is maintained in how participants engage with the intervention. Less pragmatic approaches exclude participants judged as likely to be non-adherent or failing to adhere to a minimum dose, or including special measures to encourage participation to shape client choices. Participants could choose how many in-home visits and group sessions they attended without reminders or enforcing compliance with the required dose. A minimum of 1 in-home visit and 1 group session was required to confirm intervention participation, but otherwise it was up to the participant, similar to how usual care operates. Pragmatism was slightly reduced due to provider efforts to secure minimum doses of certain CPP components. Overall, we assigned a score of 4 out of 5 for Domain 6 because participants retained flexibility and engagement with only minimal measures to secure adherence. Domain 7 focuses on follow-up procedures. A highly pragmatic approach involves little or no follow-up, similar to what occurs in usual care. Outcome data would be obtained from routine medical records or administrative databases, with nothing more collected than would be available in usual care. In the CPP trial, follow-up was more intensive because many patient-relevant outcomes were not captured in routine clinical or administrative data. Outcomes such as quality of life and self-management capacity were important in our study, given its patient-centered focus. However, these data were not available from routine databases, so the data were collected using in-person questionnaires administered by trained research assistants. The collection of these data required additional visits and staff resources, which reduced the level of pragmatism. We assigned an overall score of 3 out of 5 for Domain 7 due to the need for additional data collection activities beyond usual care. Domain 8 focuses on the relevance of the primary outcome to participants. In pragmatic trials, outcomes should matter to patients and be relevant to providers and decision-makers. The primary outcome for the CPP trial was quality of life, physical functioning. Secondary outcomes included those likely to be important to patients, such as mental functioning, depressive symptoms, and diabetes self-management. Additional outcomes captured clinical measures such as blood sugar level and healthcare costs relevant to clinicians and decision-makers. Because outcomes were selected that were meaningful to key stakeholders like patients and policymakers, Domain 8 received a score of 5 out of 5. Domain 9 focuses on intention to treat analysis. In pragmatic trials, participants are analyzed in the groups in which they were originally assigned, regardless of adherence or deviations from the intervention protocol. Although it may seem intuitive to exclude participants who did not receive the intervention, a pragmatic approach keeps them in assigned groups to reflect real-world practice. The CPP trial was highly pragmatic. Participants were kept in the groups to which they were allocated, and recommended statistical methods were applied to account for missing follow-up data. Multiple imputation was used to impute follow-up data for dropouts. Overall, we assigned a score of 5 out of 5 for Domain 9 because the analysis reflected real-world practice by retaining participants in their assigned groups and accounting for missing data. This spider plot summarizes the trial design across all 9 PRECIS-2 domains. Overall, the trial was rated as pragmatic to very pragmatic, with a score of 4 out of 5. This design supports the generation of evidence that contributes to the existing CPP evidence base and helps facilitate implementation, spread, and scale-up of the intervention. Designing research that produces useful and applicable evidence requires clarity, transparency, and intention. As this example illustrates, trial design involves deliberate decisions across multiple domains, from who is included to how outcomes are measured to how data are analyzed. The PRECIS-2 tool offers a structured way to assess and align design choices with the desired level of pragmatism. It encourages researchers to reflect on how closely their trials should align with real-world care and where meaningful trade-offs may exist. If you are planning a trial or looking for guidance on how to integrate pragmatic decisions into your trial design, consider exploring the PRECIS-2 framework. To learn more about pragmatic trial design, patient-oriented research, and aging-focused health research, connect with the McMaster Collaborative for Health and Aging.